good quorum here, both in person and then on Zoom. So we'll go ahead and get started with our grand rounds today with Dr. Stavros Drakos coming from University of Utah. And then I met Stavros first through the Abbott heart failure course. I want to thank Liviu who introduced me to the course, and that's where we all talked. And then I'm very happy that he found the time to travel here to share with us his expertise in myocardial recovery. So a little brief introduction. Dr. Drakos is currently a professor of cardiology and physiology at the University of Utah and hosts the H.A. Aetna Benning Presidential Endowed Chair. A little bit about his education background. He started all his trainings, including MD, PhD, internal medicine, and general cardiology at the University of Athens. His PhD thesis on pulsatile versus non-pulsatile mechanical circulatory support and the porcine model of heart failure was awarded the top PhD thesis of the year at the University of Athens. After general cardiology training, he traveled and moved to the US and completed his advanced heart failure training at the University of Utah. After training, he returned to Greece and started the first VAD program in the country before joining faculty at University of Utah in 2008 and has been there since. Dr. Drakos' research is focused on cardiac recovery in both chronic heart failure and in acute setting. The original work generated by his research team led to the establishment of the award-winning multidisciplinary Utah Cardiac Recovery Program. And he also co-directs the annual International Utah Cardiac Recovery Symposium, which has been held for the past 13 years and actually just took place last week in Salt Lake City. So again, very appreciate Dr. Drakos taking his time to now travel here just after the busy conference and to share with us his expertise on myocardial recovery. So now without further ado, I'll hand over the mic to Dr. Drakos. Thank you.
Thank you, Evelyn, and thank you everybody for coming and for this kind invitation. It's great to be here among friends. I saw earlier today Ted and Mark, and I'm looking forward to meeting more of my colleagues later. So we'll talk about recovery, and I'll start with some general concepts. And as you know, reverse remodeling and recovery is something that we experience every day in our wards, in our clinics. And this is a table which is very busy. And the purpose is not to go through all of these etiologies that you see there or through the therapies that they're listed in the second column or through the response rate that you see there, variable response rates. The timing to response is variable. The durability of response is variable. The point of this table is that a good reminder that this is a heterogeneous disease, and both HFrEF and HFpEF. And we'll come back to this point. Now, this is a diagram put together, this illustration by Ken Margulis years ago, and I really like it because it just shows to us things that we do every day in order to make a bad heart look better. In the outer ring, you can appreciate the mechanisms that they are responsible for forward remodeling. And in the inner ring, all of the things we do every day in order to mediate recovery. Is the pointer from the mouse or? It's just your laptop. Oh, okay, here. Great. Okay. I think I messed the slide. Right? Sorry. Maybe I did something wrong. Maybe you can just bring it back. Because maybe I just escaped and okay, here it is. I'm not going to touch it. It's okay. We don't need a pointer. It's fine. There. Okay, good. So you can see here beta blockers, other medications that we use, as you know, controlling tachycardia, resynchronization therapy, fixing valves, all these things that we do in order to make our heart look better. And I'll submit to you that from all these interventions, one that may help us to get additional clinical and investigational insights is the left ventricular assist device intervention. And we'll talk a little bit more about why these could be more helpful in gaining further insights. Now, the load and the wall stress, we know from work by Drakos and many others, that it's central in this vicious cycle of heart remodeling and the progression of heart failure. And the hypothesis generated years ago was that by removing maybe a significant part of this load with these devices, we may reverse this process. And these devices, on top of removing a significant part of this load, they also improve the systemic perfusion and the neurohormonal milieu, which, as we know, is very important in heart failure, given that most of the therapies we use, they target the periphery and not the muscle, right? So this is a patient, and you can appreciate here in the 4-chamber view, we call this patient a responder, how the heart got better after a few months on the left ventricular assist device. And here's another patient who did not get better despite similar heart failure etiology, duration of disease, and duration of the intervention. And understanding why these two hearts and the spectrum in between responded differentially has far-reaching, we think, implications. So that's what brought me back to the University of Utah. We were doing work like this in Europe after my training in Utah, and I started the program there, as Evelyn said. I returned back to start this program, which has a clinical and a scientific component and collaborations with institutions throughout the country and the world. And I'm just going to go and review primarily some of the clinical research findings over the years, given that the audience today is primarily clinical. Review at the end some translational findings as well. Essentially, to summarize at the beginning, what I'm going to share with you on the clinical research side. These are some of our trainees, mentees that they worked over the years on some of the projects that I'm going to mention. This is Dr. Bonyas that Ted and Roselle mentored in Hopkins for years before coming to Utah and being mentored by us as well. And these are people that now most of them are faculty. And one of the things we learned over the years was this reverse remodeling is not binary. It's not all or none, like pregnancy or death. It's a continuous phenomenon, takes place as a spectrum of phenotypes. And we will expect, with the current way we treat advanced heart failure patients, you should expect to find about 15% recovery responders, and we'll talk about what this means, 30% partial responders, and about 50 to 55% non-responders, and we'll come to this point. Another thing we learned over the years by work in our program and others is that the sustainability of this remission/recovery after you win the LVADs is really good, and we'll talk about that. It's reproducible throughout the world, and now we can predict who are the people that they can respond, and guided by these clinical predictors, we can select them with a likelihood of up to 70%, depending on the predictors. Currently, it's underdiagnosed and underutilized. That's one of the reasons we're talking about it, so we can define the magnitude of opportunity, missed opportunity, and we will talk also about some future directions that can impact broader patient populations, not just the advanced end-stage LVAD patients, and some of the things that are happening right now, bench to bedside. Now, pre-stage is a study that was published already 4.5 years ago. It was a multi-center study. You see the sites that were participating, enrolled 40 people, and they were selected, these patients, based on single-center studies that were done in the past, showing that these patients have higher chance to recover, non-ischemics, less than 60 years old. The hearts were large, all of them, but not more than 5 years duration of disease. And 50% of these patients met the criteria, and the pumps were weaned throughout the 6 sites, in all 6 sites. And that was a good outcome, but the population was enriched, selected, right? So the question in the field, it's a big question in the field, is what is the incidence in all comers, including the ischemics? And it's a big barrier in the field, the concept that dominated for years that this is probably happening rarely. And we are we wasting our time looking for rare zebras, right? And if you want to look at the incidence and look at the all-comers, Intermax, which is the national registry, is a good way to start. So this is Omar Weaver-Pinzon, who is a K-funded mentee that we just exported to the University of Miami to lead the program there after being with us for many years. He did a lot of work with us, and we're proud of his accomplishments. And Omar, one of the things he did is that he took the Intermax data and he looked at the echoes that were uploaded by every institution, including UCSF or all institutions in the country. And he identified there that we all know that only 1% of the patients, most institutions don't have recovery programs, were explanted. And then he focused on the rest of the echoes that were uploaded by every institution. And then there were around 7,000 patients that they had serial echoes in the dataset done at every institution. And he just read the reports. And this is what he found, that there were about 12.6% of the patients, in addition to this 1%, that they had an EF over time that increased to more than 40%. So if you combine the two, it's about 14%. And then he also found that there were other patients that they had variable improvement in their function. We call those partial responders. As we said, this is not an all or none phenomenon like death or pregnancy. And these had a median ejection fraction increase of 9% and a range between 6 and 14. And again, these were echoes uploaded by our coordinators from all over the country, and they were just the reports read by the team. And this is the magnitude of the missed opportunity. Some people think that this is an underestimation. The reason it's an underestimation is because even in our center, at the end of the day, a busy echo reader sees the LVAD there. They check the box of severe LV dysfunction sometimes without spending all this time to calculate the volume. So many people think that this is an underestimation, actually. The Columbia group got the same Intermax data about the same time. You see here Veli, who just left to lead the program at the University of Wisconsin, Milana and Paolo, and published this paper. They found exactly the same thing, of course. It was the same echo reports in Intermax, found the same percentages. And then when we went a little bit more granular between Innova in the DC area and Utah to have diverse populations from both sides of the country, we get patients from about 10 states through our VA and through our Mountain West connections. And the DC area is also diverse. And these are the patients we evaluated here, almost 360 patients. We excluded the acutes, that they have this propensity of recovering more. These was just only chronic people. And the program there was led by Palag and Mitch. And I think Mitch used to be here, right? And Joe and Christos led the program on our side. And we found essentially the same thing. Now, back to the zebra issue. Yeah, this should not be dogmatically considered like it's going to be a rare zebra. It's not for everybody. You saw it's not the majority of the patients, but it's something that we should look for. And we should be reminded that in our field, we have done this in the past a couple of times and other fields as well, right? The beta blockers was considered a rare zebra for decades. We just had our recovery symposium. Bristol was giving the talk, reminded of everybody that the beta blockers were working only in Utah and Sweden for 20 years. And you went to Colorado, they worked there as well for another 5 years. As you know, they work everywhere, on everybody. And the AMR is another example of something that was considered a rare zebra for decades. So dogmas in academia and academic medicine and medicine in general should have no place. Now, defining recovery is something that troubled the field, and that's why we got together. I had the honor and the privilege to lead this consortium of colleagues a few years ago, where one of the questions we asked in this workshop was funded by the NIH was, what is recovery? We gathered, and one of the things we agreed on is that it's not just the reversal of the state of the heart with significant improvement in structure and function, but you also need to have sustained remission from recurrent events, right? That's what is meaningful for the patients. And the recommendations are on the NIH website, and they were published in associated journals that you see there. And based on this definition, the durability of this recovery and remission, right, is important in the events. And looking at the sites that they had recovery programs, one of the most well-known is the one in Herfield, where Emma Burks and Sir McDiarcook, my mentor, who introduced me in this field during my time there, and the collaboration we had later with them when I was at the University of Athens. This is patients from their experience. With red are the explant patients they had, and they compare them with the alternative therapy, patients that they got transplanted. And you can see here that up to 8 years of follow-up, the results were similar, which was pretty good. And other centers, you can see here, were reporting similar things. But the numbers, as you saw, were small, right? In this table, you see the numbers. And when you're trying to do things outside the mainstream, small numbers are not going to get the attention of people to change the way they practice. So you need big numbers. And you can see here the results were good, right? But the numbers were small. And that's why we got together a couple of years ago, and now we have a network. And you can see here from all over the world, we have more than 55 sites now, and we have more than 800 patients that the pumps were removed for recovery. And the purpose of this is to follow them chronically, see what happens to them, right? And through this network, which is a wonderful opportunity for collaboration, we are learning now things. We clean up the data on almost 450 people. And these are some preliminary results that we presented at ESC, and the paper is under review with more patients right now. And you can see here some of the baseline characteristics, expected patient population. One of the things that impressed us was that 30% of the patients were older than 50 years old. As we will see later, age is not coming up always as a predictor. And these are the echo parameters, standard echo parameters that you would expect in end-stage patients before they get the LVAD. 20% of them, these are people that they met the criteria and they were explanted, right? They had 20% RV dysfunction. And you can see here hemodynamics. And these were really sick people, as you can appreciate from the temporary MCS that was required to bridge them to LVADs. Now, when we got together in order to publish this, we thought that a good comparator would be like the Herfield study I showed you, an ISSLT propensity matched group of patients based on baseline characteristics with the alternative therapy, which is transplant. And these are the results out of almost 300 patients that they were matched, right, with a long follow-up. And you can appreciate here that the long-term outcomes and the durability is really good without having to use immunosuppression, keeping your native heart, which invites the concept that we will address down this talk, maybe combine sequentially these two options in order to achieve what we now are aspiring in our field for a net prolongation of life for our younger, especially patients. Now, we'll get back to this point. Another thing that impressed us, and the Duke group is focused on these partial responders in a sub-project that was just presented, and we're writing up the paper, is the so-called partial responders. The people that they didn't meet the criteria with the blue line, and the pumps were removed because of a complication. These are the patients that their EF went from 5, 10, 15%, maybe to 30%, 35%. And they were in the woods. You couldn't put another VAD. They were not transplant candidates. But I'm sure you had patients over the years like that they troubled you. And they just said, okay, let's see what happens. And we were expecting them to go boom down. And as you can see, just a majority of them converted to what we call stable HFrEF outpatients. This is Bud Frazier and others over the years saying, you cardiologists see all these stable HFrEF outpatients. Maybe some of these patients will be like that. And this is what the Duke group is trying to identify, predictors that can tell us who are these people that they will get partial response and then will have good remission of their heart failure, which is something that is of interest to the field. Now, across the heart failure etiologies, we said at the beginning of this presentation that this is a heterogeneous disease. So one of the projects that we presented at ESC, and the paper is under review as well, is across the etiologies, what's happening. And you can appreciate here that the long-term outcomes across the etiologies are comparable. As expected, the chemo-induced, we know this from our cardio-on colleagues. Javed joined us yesterday with his team, and we talked about it. And cardio-oncology is booming, and chemo-induced cardiomyopathy is probably one of the worst etiologies. Maybe here, but it didn't reach significance. So we'll see how it evolves. And then when you look at the EF over time, you can appreciate here stability as well across etiologies. A popular question, I see our surgical colleagues here, and thank you for making time, is, are we going to take the pump out surgically, or are we going to decommission it in the cath lab and put an umbrella there and just bury the exit side? I cannot break the news because it's going to be presented in Boston in a couple of months. I can just tell you that it was about the same, maybe a little bit more infection in the decommissioning. We do explants. And after these results, even our surgeons are saying maybe in older people that surgery may be an issue. You can just do that and see what happens. But we're looking, it's a deep dive now in this project. There are many projects that they are ongoing. We presented last year in National TNESC about 10, and there are 9 more presented this year. As I said, this is a wonderful collaborative effort. You can see here surgeons and cardiologists from all over the world that you can connect with in order to be involved. And we have 4 working groups now that they are led by good colleagues. One of them is focused on how to win and developing standardization and protocols. And Emil Najar from Karolinska and Kuei Ton from MGH are leading this one. We have one that is focused on the winning, post-winning long-term management, and Risha Garwal from Duke and Milana Yusefolskaya from Columbia are leading that one. We have one focused on the surgical approach with Alex Bernard from Hamburg and Stefan Schuller from Newcastle, and one focused on genetics with Carles Diaz from Barcelona, Omar Weaver-Pinzon now at Miami, and Ray Hershberger at Ohio State. Now, it's not all about survival. I showed you mostly long-term outcomes, and I showed you also EFs. This is exercise capacity data from a multi-center study in England, and you can appreciate with blue there the exercise capacity of the healthy volunteers, and with orange the patients that the pumps were removed. And you can see stratified by age, good oxygen consumption, better than the triangles with gray, which are LVAD patients, and better than, of course, end-stage patients waiting on the waiting list with purple squares. And over the years in this exercise capacity quality of life study, you can see the good durability as we discussed before. Now, practically, when we are doing our selection meetings, we just did one this past Tuesday. I don't know what day you do your selection meetings. Tuesdays are good days because Mondays you want to gather the pieces from the weekend, right? And then on Tuesday, you just talk about people and how to put all this together when we're dealing in this big room with everybody, right? And implement shared decision making. So this was one of the things we discussed at this workshop that was done a year and a half ago at the NIH and led by Lynn Stevenson, Alana Morris, Frank Pagani, and Renee Wong. And one of the things we discussed there as an opportunity is maybe improve durable MCS utilization as a complement or alternative to transplant. And maybe if we can identify reliably recovery candidates, we can delay or obviate transplant for later, right? And this way help them. And essentially what this is talking about is if you have a patient in front of you in your selection meeting that you do know that this patient is prone to recover, may not be the best strategy to go straight to transplant. Maybe you can try first VAD and optimal GDMT, and if recovery does not happen, then you can proceed to transplant later. This can be especially attractive in young and middle-aged patients. Now, why in young and middle-aged patients this may be more attractive? You can see in this ISHLT data from other 50 years right now. And the reason is that these people, right, they were going to get 13 years if they are 18 to 39. And if you're 40 to 59, you're going to get 11. And when you're young, your dream is to live longer than that. And this is with retransplantation. That's the fallacy that we think that retransplantation, it's not more than 5% of the cases, right? We have all these problems. And why we cannot retransplant people? Well, we cannot retransplant people because they get all these issues that you guys are very well aware. You have a busy transplant program, excellent team here. So you're dealing with these problems all the time, right? And I'm just going to focus on the diabetes because my partner, who is the ISHLT president, Joe Stelick, just put out this and presented it, where they focus on 2,600 post-transplant patients with diabetes. And what do you think was the outcome of these patients after 5 years? Which, as we saw here, it's 30% of the patients after transplant. Well, it was 50%, which is what we teach our fellows, that when you are diagnosed with heart failure, your 5-year survival will be 50%. So in 1/3 of the patients, that was the 50% mortality within 5 years. Malignancy is another problem. So for all these reasons, retransplantation is not always a solution. So this is the latest Intermax report. Of course, VADs have also complications. You can see them there, right? And you've been dealing with them. They're getting better, especially in young people. This last report was focused on young people. They get better in young people, but they're still there, right? And the idea now is maybe try to combine the two, right, in order to get more longevity. But when you have a patient with recovery, instead of just adding the VAD and then the transplant, you may add a third component, which is a VAD leading to recovery, and then adding an even bigger advantage to this patient. Now, we talked about the implications, right? So avoid complications of immunosuppression. And if many years later heart failure comes back, we can offer transplant at that point in time. These donors, as you know, are not going to be wasted. Somebody else will get them. The congenitals, the HCMs, all these people in the waiting, we don't have donors for everybody. So it's a win-win, right? It's a win-win. It's going to reduce the wait list mortality, and it's going to help maximize the impact of both therapies. Now, practically, when you are in places that they don't have a lot of donors, you guys have more than the average usually in this area. I'm not sure how much more, but that's the rumor, right? But if you go back east and you talk to them about that, they will tell you, well, if the patient on an LVAD doesn't recover, he's or she or they are stuck on an LVAD. So what we're talking about now with UNOS is the kidney safety net, bringing it to the heart. So what is the kidney safety net for the uninitiated in the room? The UNOS is telling you, if you have a borderline patient with kidney dysfunction, don't take the donor, just go for the heart. And if you need the donor, if you need the kidney later, the patients with immunosuppression get kidney failure, we will give it to you later. Why they do that? Because they want you to give the kidney to somebody else. And they incentivize you to do that. So we are talking to them about doing something similar. We are doing now in this open comment period, a thing we submitted last time with 25 sites co-signing. This time we will get many more sites to co-sign, and we will invite you to co-sign as well. Essentially, we want to incentivize clinicians and patients to try first the recovery path in selected cases with high chance to recover. And we can talk about that. And if you don't recover, you will be rewarded with wait list priority later, right? It's also similar to the living kidney donation. If you give one of your two kidneys and you need a kidney later, they reward you. They incentivize you to give your kidney because they will give you the kidney later. Now, the question becomes, which was the topic of my talk at the workshop at the NIH that Lynn wanted me to talk about, okay, who are these people? Who are these people? So on your selection meeting on Tuesday, who are these people? Can we identify them? So we can inform the shared decision making, right? So patient selection, predictors. We've done work on this. It's one of the first things we did. We went deep, we cut the tissue. You're familiar with the ryanodine receptors, and we identified that when you have the ryanodine receptors looking like sheets with the T tubules, right? And they are not coupled, these people are not going to recover. But you cannot, on your Tuesday selection meeting, just go analyze the T tubules and figure out who is going to recover and who is not going to recover. You need something more simple to do, right? So the editorial talk about the point of no return. Maybe this is one of the microstructural characteristics. We want something more simple, right? Fibrosis. People are saying, well, we can do fibrosis. We can do MRIs in these people. If we can bypass the artificial pacemaker. We looked into that. This is, you can see the fat of the epicardium and the endocardium. We did fancy ways to assess the interstitial and the perivascular fibrosis and the total fibrosis. We investigated that, right? And we were surprised when we saw that there was a big percentage of patients, you can see them here, that despite being advanced end stage, the fibrosis was low. When we saw that, we were shocked. We said, oh my God, people will say we don't know what we're doing in Utah. We're putting LVADs and doing transplants in people without fibrosis. We looked back in the charts, they were as sick as the others. We kept analyzing, we are now at 142. And indeed, there's a German group that just reported the same thing. There are a lot of end-stage advanced heart failure patients without fibrosis, without increased fibrosis. They still have fibrosis, but comparable to the donors. Anyway, the question we were trying to answer in the high fibrosis group is whether fibrosis can help predict the response. And we were surprised again, because the ones that they responded, they had decrease in the interstitial fibrosis, which is consistent with what we now know from AES patients, that the replacement fibrosis and the scar from an MI is not going to reverse, but the interstitial fibrosis is active and it can be reversed. And what we were surprised to see was that the pre-LVAD, pre-intervention interstitial fibrosis was not a predictor. This is Michael. He learned torsion and rotational mechanics from Ted when they were in Hopkins. And then when he came to us for his fellowship, we took advantage of Ted's training. And Michael did this project. And the hypothesis here was that all of these people have low EF, but some of them have better rotational mechanics despite equally low EF. So maybe this is a marker of a healthier heart. Maybe the remodeling is not so severe. Maybe this is another point of no return. And indeed, in this paper, what Michael showed before returning back to the Onassis Center in Greece to lead the program there was indeed this could be a predictor. And people with low EF that they retain torsion and rotational mechanics, they are the ones that they tend to respond. But as you know, rotational mechanics, and we talked about this with Ted when he was visiting the other day, is not at every institution at the forefront. It's not something you can do so easy. You would like to do in your Tuesday selection meeting something that everybody can do, and they don't need a super duper echo lab like the one that Ted was running to train people like Michael to do that. And so we started looking at biomarkers, and we did analysis in our tissue from these patients, and then we went to the blood, and guided by the tissue findings, we saw that the TNF-alpha and the interferon gamma could be predictors. And that was good, and it was predicting, but still, our lab doesn't measure TNF-alpha and interferon gamma every day, right? So can we do this in a more practical and precise way, right? So this is Omar again. When he did the Intermax analysis, he also created this model. You can see here a bunch of predictors that we identified. And if you put them in this score, you can get these percentages. And you can say, based on this model, these are some tiers. Patients, they need something more simple than that, and the teams. And this is good. We've been using it, but we wanted to make it even more practical. And that's why, in order to be even more practical and personalize the prediction, we got together and we created this calculator now. So the first 4 sites that you see there, they are the derivation cohort. And then the last 4 sites are the validation cohort. And we identified 4 characteristics that you can easily put in the calculator: etiology, gender, sex, heart failure duration, dilation of the heart. And then you can make a personalized prediction. By the way, as Livy reminded me when we were talking to the fellows a few weeks ago, these are similar predictors of response in other things we do, GDMT, CRT. So this is not science fiction or something exotic. This is consistent, right? This is how we can predict response. So this is a lady, 72 months out, LVDD 6.6, 25% recovery. This is another lady, 44 months out, 65 millimeters ventricle, 30%. This is another patient, 11 months out, LVDD less dilated, 40% recovery rate. And this is another example, another lady, 6 months out, not dilated, 50% recovery rate. So this is how you can begin informing your conversation for shared decision making. What we are planning to do here is what we did with RV prediction. This is just published in JAMA Cardiology. You can go on the website and calculate every week at your selection meeting the personalized prediction for RV failure. Because if you're going to do recovery, you don't want to recover the LV, you want the RV to do well. So this is useful as well. And we will do the same for the recovery calculator to make it available. The paper is deep under review right now. The next step is combining the clinical characteristics with the biological data that I talked to you about. And that's another thing that we are trying to do. And the whole idea is to help overcome this underdiagnosis and underutilization of the cardiac recovery path. That's the opportunity. It reminds you a little bit of the amyloidosis, which we all think that is underdiagnosed. The magnitude of the opportunity is that if you go to Intermax, as we said, you will see recovery rate between 1, 2, maximum 3%. Most sites don't have recovery programs. They are getting better now. But if you look at the same Intermax as we just shared with you, you will find 10 times more patients that they improve their heart function. So that's the magnitude of opportunity. That's the missed opportunity, right? So this is in Intermax. So the Mount Sinai group just got the data from UNOS, and they found the same thing. Essentially, what the group, and actually the surgical group, Annie and Shinobu led this with the cardiology team there. What they found there was that they divided the sites in the country in two, and they said some sites they do 5, 10, 15%, 20% recovery rate, and most of the sites zero. And the argument they're making is that these other sites, they don't see different species of patients. I mean, the patients are the same. So that's the missed opportunity they identified, and they talk about underutilization there as well. Now, as we said, this should not be dogmatically dismissed as rare zebra. Now we have patients that these are the percentages that you should expect. We have now from all over the world sites. This is not like the old days, the super duper Sir McDiacube in Herfield or Bud Frazier in Texas Heart. This is hundreds of cardiologists and surgeons from all over the world. So this is not something so complicated. And what do the guidelines say? We talk about the things that they're out there. They summarize the literature even before the registry was developed. They released these guidelines, as you know, a couple of years ago. Now the guidelines give instructions on how to select these patients, how to optimize them, and how to evaluate them for recovery. So practically, when you're talking about action items to take advantage of the opportunity and looking in the barriers, right? The fact that recovery programs don't exist in many sites, it's something that should not scare us, because as I will share with you, and I think this is the most important slide of the presentation, is that it's simple. A recovery program is a 4-pillar GDMT, which we're supposed to do anyway, and an echo every 3 months for the first year. Yeah, it needs some coordination, but it's not something super complicated. And then as you screen the patients, when you see the EF going more than 45%, you can proceed to the weaning evaluation, which essentially is turning the pump down to the minimum and do an echo and a right heart cath. The CPET is optional. And these are the criteria used in restage and most of the studies out there, essentially normalization of the hemodynamics. And you see the cutoffs on the dimensions and the EF. Now, what we are trying to do on top of just turning down the pump for half an hour in the cath lab, we are turning it down and leave the patient in the ICU with a SWAN as a protocol to see how these will change in the ICU. We have not found a patient until now that will change. Actually, they may get even better because the heart may be shocked when you just do it in the cath lab, but we're doing this as an additional step. So what was another barrier in the field was this uncertainty about the durability of this remission. Not anymore. As I share with you, we have now data from all over the world and even a registry with hundreds of patients. Another barrier was how to select these people. Well, not anymore. We have Intermax-derived scores. We have a calculator that is under review right now. And we kind of know from restage and other places who are the people that they will be more better candidates to recover. And we are talking to UNOS, as I just shared with you, in order to incentivize people so they can transplant these patients later if they wish, if they don't recover or whatever, right? Now, this is interesting. Have you ever had a patient come to you and then you want to send this patient back to the referring cardiologist and this patient doesn't want to go back? You've been there, right? It's a very awkward. So in this case, it was even worse. The patient needed to go back to New York. They sent them to us from a New York program that they didn't have a recovery program to remove the pump because their surgeon wanted our surgeon to do it until they get more up to speed. So then the patient is supposed to go back to New York and the neighbor of the patient texts the wife this, and she goes like, you should not go back to that hospital. You should go to Montefiore because they have a recovery program. And that's why you went all the way to Utah. And then we had to call back these referring cardiologists from New York to tell them, the patient doesn't want to go back. And it's a position that you don't want to be at. So this was one of the chiefs of the police department there. Future directions. We talked about this missed opportunity here, right? And I would like to introduce a couple of other opportunities there. And is there any room for improving the GDMT and hemodynamics for these partial responders or the non-responders, right? And you can see here that there's lots of room to improve the hemodynamics. This is data from Chicago and Innova. And you can appreciate that there's a big percentage of patients, despite feeling okay on an LVAD, that the hemodynamics are not where you want them to be, inviting the concept that if we do a better job, we may be able to recover even more people. And how can you do that? Well, we are at UCSF. You guys are a big place when it comes to sensors, right? CardioMEMS is one of the sensors. And this is the Intellect 2 study that I had the honor and the privilege to lead. we call it with my colleagues here. And what we found there was that in LVAD patients, sensors can work well. It's feasible to combine them. And if you maintain the PA diastolic less than 20, you can significantly lower the heart failure hospitalizations and improve the 6-minute walk test. And this is the magnitude of the improvement in the 6-minute walk test and the reduction in the hospitalizations. Now, based on these, and from what we learned in this pilot INTELLECT-2 study, there's another study now called TEAM-HF, which essentially is trying in HFrEF patients that they have cardiomems to prospectively examine the PA pressures. We are part of it. I don't know if you guys are part of it as well. So you're part of it as well. That's great. And when it comes to sensors, as I said, UCSF is leading. So the idea here is that if after GDMT, the patients still have mean PA more than 35, they are identifying as high risk for bad outcomes, and maybe we can randomize them. This is trying to randomize for LVADs patients one step earlier than what we really do now. Get in less sick people and identify a high risk group that can benefit. And of course, it's a study, and that's the hypothesis that these patients may do better. And our prediction is because this is going to be a less sick population based on the predictors I just showed you before, the recovery rate in this population would be even higher. Now, is there room to improve GDMT? This is embarrassing for all of us, but this is the reality. Unfortunately, there's only 15% of the patients in INTERMACS that they are, when this study was published, on standard triple. I know that we have patients that don't tolerate GDMT, but we can do better than 15%. And that's the missed opportunity there as well. Now, moving forward, who are the study populations that we think there is opportunity? Well, the GDMT naive or intolerant to GDMT patients, that they are shocky and they have been supported with temporary MCS. With the current allocation system, they can just be transplanted very quickly, as you know. And it's a temptation sometimes, because you just have a patient, the kidneys came back, and Impella is there, and you can just transplant this patient quickly. But this is the right thing to do. And that's a population that we think we may have to look a little bit more carefully and try recovery more. And there's increasing role of temporary MCS. And as you know, the Impella 5.5 are developing an Impella bridge to recovery. So they can even discharge these patients if you need more time on GDMT. The bad news is that within a few months, when the allocation changed, because of this scenario, and this is what we published, the temporary MCS patients that they were recovering went down by 9 times almost. And, you know, the patients didn't change within a few months. But because the allocation system was giving you priority in these patients with temporary MCS, it was just easier to transplant them. And that's why we want to incentivize now the opposite behavior, and we're talking to UNOS. Another population that is, we think, something we can do better is all these people that we all have that they are walking around wounded on a touch of GDMT. You have patients like that. And maybe these patients is also a population that we can do better. And of course, the ones with the predictors we just discussed. Essentially, the idea is to rescue some hearts and avoid transplant, especially in young and middle-aged people. Improve the allocation, because these precious donors will go to people that they won't recover and they don't have another option. So everybody will win. And of course, another advantage of this field is that it's informing how the heart can recover. So it has a huge translational impact that can impact beyond the end-stage population. So I'll share with you now a little bit on what we're doing there. And this is a paper we published with Mandeep Mehra about ongoing research targets, and that was one of them, right? Molecular and mechanistic insights. And I'm going to spend a little bit time there. Again, we don't have a lot of time, so I'm not going to go into the details, but identifying mechanisms of recovery to develop novel heart failure therapies for the broad field, not just for the advanced, is, I would say, an even more important reason we started this program. So this is Dr. Cheyu, who is now a K-funded junior faculty with us. She's been working with me and others for years. She summarized here with colleagues that you see listed there, the field. Recently in an invited review paper. These are the biological changes you would expect in the cardiomyocyte compartment. the vascular compartment and the non-cardiomyocyte compartment of the myocardium. And essentially, the strategy we are following in order to identify these targets and gain mechanistic insights is get the tissue before and after. And when we transplant patients, we have the whole heart. When they recover, we get tissue from their myocardium, less, of course, phenotype them in order to know who responded and who not. And then do three things. The first is to screen this tissue for candidate pathways. And these may just be associations. It doesn't mean causality between the responders and the partial responders and the full responders. And then go in the lab, I go after these pathways that you find when you screen the tissue and do in vitro and in vivo studies in order to prove causality and identify mechanisms, and of course, bring them back. I'll share with you three examples that we did that, and we've done it, of course, with other examples as well, but not all of them worked, so we're showing the ones that they work. So when we were screening about these, and this is one of the things we did to screen, we did transcriptomic and proteomic and phosphoproteomic, and this is exactly what happened, right? You get the heart, you have responders, you have non-responders, and you have the spectrum in between, right? And then you do RNA sequencing, you do phosphoproteomics in order to identify these targets, all right? And to this RNA sequencing of the whole tissue and the phosphoproteomic, we also did single cell that just came out in Nature Cardiovascular Research, again with the same strategy, in order to identify these clues, where the smell is coming from in these patients, right? When you put them together, you will see this is a heterogeneous disease. The targets were from everywhere. They were not just from one pathway. This is a heterogeneous disease. So in order to see where are we going to invest first, we went back to the duration of the intervention in order to see the response. And when we plotted it over time, we saw that most of the response was happening really quickly. And that's why we started first from metabolism. That was one of the reasons we started first from metabolism. It came up. Now, this is the first example that we went and we did the mechanistic studies in vitro and in vivo, and we identified the lactate exporter MCT4 as a target that has promise in developing new therapeutics. We don't have the time to go into all of the details. I'm just sharing some examples, and the paper is out and you can review details. The second example is that came out as targets from these screenings that we were doing is this VDAC2 activation with F7. And the mechanistic studies that they are describing in this paper show that this is another target that can be developed as a heart failure therapeutic. And the third example I wanted to share with you is ABP1, which also came out of this screening. And in this paper that is under review, you can see how the fibroblast, when you throw ABP1, becomes activated. When you block it, you prevent the fibroblast activation. And we have two models, an MI model of heart failure and a systemic fibrosis model that when you block ABP1, you can prevent the badness and you can improve the heart function. And again, this is another example of how you start from the human, you go back to the bench, you find something and you try now to bring it back as a heart failure therapeutic. As you know, we failed a lot of times when we start from the animals, and we think that this approach to start from the humans, narrow the list of the targets in the human screening, may increase the likelihood that you can bring it back as a new heart failure therapeutic that works for humans. As we know, and as we talked about, there's a lot of heterogeneity when it comes to this disease. And when we're dealing with adults, there's additional heterogeneity, right? Comorbidities, medication, aging. That's why we're doing studies in kids and in large animals, that there's less heterogeneity. I share with you a few of the targets that we are identifying, looking into recovering the heart and reverse remodeling. For further reading, we were invited with colleagues from all over the world. Manrit led the clinical and Eleni led the biological paper that is as companion review articles give a good comprehensive review of where the field is both clinically and biologically at this point. We just did our recovery symposium and the recordings will be available. We had interesting talks bench to bedside, complimentary to everybody. and you can visit our website. We also celebrated that day, the first heart recovery date that the Congress designated, and they made us the honor to designate it at the first day of our symposium. And this is our team. We every year do a funny picture. We are overdue. We didn't do one since COVID, but we do a serious picture as well, and we did one. So that's more recent. And these are some pictures from our valley, and we are recruiting for your anybody interested from your fellows. And of course, acknowledgements to my colleagues and collaborators in our institution and throughout. Thank you for your attention, and I'll be happy to discuss a little bit more about these concepts.
Thank you, Dr. Drakos, for that great overview, clinical